Hello, everyone. We are going to, in this presentation, take a look at interpersonal psychotherapy, or IPT, as many people call it. Interpersonal psychotherapy was developed in the 70s, early 70s, by Clearman, Weissman, and colleagues. And since that time, it has been shown to be effective with a number of different disorders. This week you read in particular about the use of IPT with depression and mild and moderate depression, which is where it got its start, like a number of different therapies. But really outside of some of the specific things they talk about for IPT with depression, it's been generalized and used now with a number of different populations and with a number of different disorders. So what we're going to do is to look at kind of how IPT proper is conducted. As we've talked about in teaching this class, you may do IPT proper as we talk about it here, but I think more importantly, it gives us another demonstration of how we can use the interpersonal relationships and the interpersonal domain as part of our treatment based on what our conceptual model tells us about our clients. So let's go ahead and get started. We're going to go ahead and get started with the area we usually get started on, and that is talking about kind of conceptualization and case formulation. Again, those words mean the same things. So we're going to talk about how do we understand psychopathology from an IPT framework and through the lens of IPT therapists. And in doing so, we're also going to be considering some of the goals of IPT and what we're trying to accomplish. And again, I'm using this as though we're doing it in a proper format, and the only thing we're doing is IPT. This fits for everything. So as we conceptualize what's going on in a particular segment of our therapy or a particular session even of our therapy, this is the framework that we're going to be using. So, and I've given these direct quotes from the reading, just because I didn't think I could do better. So one of the first goals is to identify specific life events and interpersonal issues as they're temporally and thematically related to the onset and maintenance of the symptom. In this case, they've talked about depression. The idea here is that our interpersonal world, the things that happen in our lives, lead directly to the onset and the onset of these symptoms. One of the secondary goal then for our clients is to help them to better understand these connections. So how do I understand how my relationships are connected to my symptomology? And again, if you're using this model, this isn't usually a hard sell, right? Clients come in and they say, oh, you know what? I had this stuff happening, or I had this thing happen in my life, or I lost this person in my life. And ever since that occurred, I've been experiencing sadness or anxiety or eating disorder symptoms or whatever those symptoms are. So this isn't usually a hard sell to connect these two things for your clients. But the idea here, and just to contrast it with other things we've talked about so far this semester, in one instance, we're talking about the way we think is related to the way that we feel. In another, we're talking about the way that we behave might be related to then how we feel. Here we're talking about our interpersonal relationships and how they're related to how I feel. And again, so although we want people to feel better and function better, again, as I've been teaching you all semester, we're just taking a different route here, and we're going in through the interpersonal route and looking at changing their interpersonal relationships with the idea that if we do this, this will then change as a result. Then the final goal of IPT is that, and actually I think I just alluded to this, I was ahead of myself again, so to learn that by kind of altering these interpersonal situations, by making them better, by doing something different, we can then change our symptoms and change our functionality and recover from the disorder that we came in experiencing. So one of the first things that we do in IPT, or if we're doing IPT-based interventions, is we want to identify the specific problem area that's contributing to our clients' difficulties. Another way of thinking about this is there's different types of interpersonal problems or difficulties that people face in their life, broadly speaking within this model. And once we identify kind of which type or which problem area our client is currently experiencing, we then use an intervention that's tailored toward their specific area. Again, in IPT proper, the suggestion is that we often identify the most important area related to our client's dysfunction. And this is true even if you're using and borrowing parts of this. So for example, our clients may have been going through a role transition while also suffering grief, right? They just lost someone and then lost their job. Well, as the IPT therapist, I want to decide which of those is kind of most pressing, which of those is causing the most distress and dysfunction for my client, and narrow our focus to that one particular area. If you're doing this in a more free-flowing therapy, you might say, okay, we can address both of those things, but you also still may want to start with just one focal area. As that gets resolved, then move to the second focal area that's less important. And this is a great way to kind of collaborate with your clients, because you're deciding together. You're going to give them your conceptualization, but you're going to decide together which of these they think is most important for them, especially if there is multiple ones. So let's look at the 5. I might have slipped up and said 4. There was 4 initially in this theory, and they've kind of adapted that and expanded that in recent years. So the first one is relatively simple for most of us to understand, unfortunately. Many of us have dealt with grief and complicated bereavement or bereavement. And the idea here is that the individual has lost someone of importance to them, and their symptoms are resulting because they're having difficulty grieving with or grieving and processing through the loss for them. In the second area, we have interpersonal role disputes. This is where there when there is conflict between two people. I think you should be doing this, you think you should be doing that, and we are in disagreement with that. If I put it into your personal lives, not personal lives, your professional lives right now, this might be something with you and a mentor, right? Where you think you should be doing this, your mentor is thinking you should be doing that, and there's conflict between the two of you because of that dispute. In the third area, we have interpersonal role transitions. As the name implies, this is a situation where the individual's role in their interpersonal role in their life has changed for some reason. Again, I'll stick with you all as good examples. You are in the first year of graduate school. You underwent and still are undergoing a significant role transition from either a full-time employee or an undergraduate student to a graduate student in a doctoral program. As you have all found out, this is a tremendous role transition and a tremendous change in your interpersonal roles and relationships with other people. Other examples could be changing a job, moving to a new area, marriage would fall in here, or engagement or things like that would fall in here as well. The fourth is interpersonal skill deficits. And this one is a little trickier, but it really refers to when someone has kind of, as the name implies, some deficits. I never use this word with clients if we're working within this particular area, but this is something where someone doesn't have the skills that they might need or the appropriate interpersonal foundational skills to be successful. This actually falls back into something that we talked about before this semester, where we talked about communication skills and social skills and assertiveness skills. If you find someone with interpersonal skill deficits, oftentimes you're using, as we'll see, treatment techniques that are related to those behavioral strategies of teaching, practicing, and developing skills. The fifth area, and this was added based on some work with adolescents and depression, but also parents, and specifically parents that were going through separation and divorce. So this refers to when a family unit has transitioned from a traditional family structure to a single parent family household. And so this is done usually either with it's not a family therapy, so it's either done with the child or the parent, and specifically addresses some of the transitions. You might argue that this is interpersonal role transition, but because some of the issues are so unique to those situations, they have identified this as a separate category and a separate focal area. We're going to transfer now into talking about some of the specific techniques and the process of actually doing IPT. Like many of the treatments that we've looked at that are manualized, this is meant to be a brief, time-limited intervention. So I'm going to talk about how that would look in a brief and time-limited way. Again, all of these things that we've been talking about can be adapted to a more routine clinical practice where either you have, well, it'd be harder to do it in less time, but you may have more time, and you may have more time to kind of do some of these things and not have to do them in the structured way that we're going to present here. But I like to introduce you to these structured things when we can. So the first part of IPT refers to the case formulation and intake and interview kind of phase. As we've talked about throughout the whole semester, the first thing you're ever going to do when you start doing psychotherapy, whether it's a brief or more extended version of it, is to conceptualize and find out information about your client and make sense of what's going on. I think I'm going to just throw all of these up here. There are, I forget if there's a sixth one. We're going to go with the first five. There's 5 steps to this. And the first one, we're going to make a diagnosis for our client, and we're going to assign the sick role. This one we may want to discuss in class. Students often have reactions to this in one way or the other. In almost every single one of our situations, I think we should probably be diagnosing our clients and giving them a diagnosis, obviously if it's appropriate, but we should always kind of be sharing what that diagnosis is with our client. The assignment of the sick role comes out of the fact that this particular treatment is based on a biopsychosocial and medical model, and the idea that mental illness, just like physical illness, is an illness. It's a sickness, if you will. We wouldn't say that. I wouldn't say that, at least to my clients, using that exact word. But the idea here is that just as you would if you're recovering from a physical illness, you would take the time and the energy to recover from your mental illness. And so by assigning that sick role, we give people the permission, if you will, to recover and to take time away from things that they might normally do in order to aid that recovery and focus in on that recovery. The second step, and these are defined as steps, they don't necessarily need to go in this logical order, but it's just easier to kind of teach and talk about. We're going to evaluate their interpersonal relationships. There is a particular tool called the Interpersonal Inventory. I just don't have a copy of it to share with you, but it's basically a structured way of assessing the multiple relationships that a client has. I like this idea of, and I think it's in the article, the solar system way of evaluating relationships. So in our solar system, we start with the innermost circle. These are family, friends, significant others, etc. So those people that are closest to us. And then we continue to expand out into our solar system, right? So on the outside, maybe the inside is our partners or our well, probably family goes in there, but there may be some family that's in there, and then there may be some family that's on an outer circle. I've got, cousins, for example, that I would put out here, but I wouldn't put them in that inner circle. So as we kind of go out, we look at increasingly more relationships that are more distant to our core kind of being and core functioning. And we just get a sense of what these relationships are like for clients during this evaluative state. We then establish the interpersonal problem area. So out of those 5 areas, after talking to our clients, gathering the information, we say we think this would be the best area. This seems to be the area that's impacting you the most. We come to a collaborative agreement upon that. And then we start with making our initial therapeutic interventions. A lot of these are the kind of non-specific, establishing a good relationship, establishing the goals of treatment, the techniques that will be used, all those things that we've talked about already. Those are these kind of initial therapeutic interventions that we're doing with our clients. And then we decide on the interpersonal formulation. And the interpersonal formulation is discussing with the client how we see the relationship between the interpersonal difficulties that they're experiencing in that problem area and their disruption in functioning and symptoms. So those are first 3 sessions. All of that's done during the first 3 sessions. Let's make sure I didn't miss a 6th one here. Oh, of course I did. Making the interpersonal formulation. That's actually just an extension of number 5 there. So our formulation, actually it's already in 5. Well, actually we're just deciding on it, and then we're actually presenting it to the client there. The middle phase of IPT usually contains the sessions 4 through 12. And again, these are general recommendations, right? You don't have to exactly start at session 4. You could start some of this back in session 3 or session 5 or whatever, but they're general recommendations. You want to stay, for the most part, within the framework, but you don't have to think of them as that rigidly. So what we do in the middle phase, and this is really just the heart of therapy, it's just called the middle phase because it happens in the middle. It's just really the heart of the therapeutic work work that you're doing. And once you've established, as we said, the particular area that you're working in, you're then going to apply the specific therapeutic techniques. The unique thing and the interesting thing about IPT, I think, one of the interesting things is that the techniques themselves are really brought in from different areas. So they're not unique to IPT. So you'll see this in a second. They come from many different areas of different psychotherapies in different conceptual models. Again, the unique thing about working within an IPT framework is that you're using those techniques to impact the interpersonal relationship. So again, we use a technique with the goal of changing a particular area that we've been talking about all semester. What are the different techniques? And I'm going to throw these all up here again. There are, it's a little slow, I think 8 of them here. And as you can see, these are drawn from, actually there's 7. So if we look up, let me get a pointer here. If we look, for example, number 1, non-directive exploration. Where does that come from? Well, we just reviewed it when we talked about supportive expressive psychodynamic psychotherapy. What are we doing here? We're getting clients to explore. So if there's grief, for example, we're exploring with them what a person meant to them. What was the importance of that person in your life? How did they impact you? What are some of the things that you're struggling with in the loss that you're having with them? And it's just really us kind of talking, listening, engaging those good kind of human things. In the process of doing that, we might engage in clarification of them. You mentioned, I get this, you mentioned that this person that you lost in your life was both a source of distress for you at times, as well as a source of inspiration. I was wondering if you can kind of clarify those two things and tell me a little bit more about them in those times when they were able to do those two things for you. An example of a clarifying statement or sentence. Direct elicitation of material is the same thing. I'm just going to be pulling out material. And one of the things, again, that we'll see this has in combination with both the dynamic as well as the emotion-focused therapies that we'll be talking about a little bit starting the same week, but more next week, is this encouragement of affect. How did this feel for you? Tell me more about that emotion. Tell me more about how that emotion impacted you in terms of what you did or didn't do. And one of the things that you'll notice in the example that you read about, for example, is this idea of suppressed affect. So it may be that, and I get this a lot when I'm working with patients and talking about their parents, not just in grief, but just parents in general. This idea of, I can't say something bad about my parents because they did so much for me. They were so important to me. It's like, okay, that's fine. Does it feel like expressing something negative about your parents would take away from those good things? That might be a clarifying question that I would ask, and also the objective of eliciting more information from them. Communication analysis simply refers to looking at some of those communication skills that we've talked about before. So what are the skills you have as a speaker? What are the skills you have as a listener? Are there ways that you can be more assertive with other people? Are there ways that you can improve your communication, et cetera, et cetera? As with almost anything in the therapy we do, but in particular with the IPT, we will use the therapeutic relationship. We're not looking for like transference, countertransference, and kind of the reenactment of bad relational patterns. We're actually talking more here about using the therapeutic relationship more in the kind of Rogerian way of kind of inviting them into a supportive, beneficial interpersonal interaction with another individual. And then we also have what they refer to as behavioral change. And again, here we're talking about behavioral change methods, behavioral psychology. We're going to give people directives. We're going to actually offer direct advice, direct explanations, direct guidance in what they might do. We might work with them to make analyses. So if I'm in a role transition, for example, I'm deciding about whether or not I want to stay in a job, I may do something to not make this overly complex. This is like, oh, let me look at the pros and cons, right? And then I might engage in role playing in practice, as we talked about when we looked at some of the other behavioral strategies. And the goal here is to help clients to understand how to use these and how to use them effectively by using our therapy as a place where they can practice and get feedback. And then in the final phase of the IPT model, sessions 12 through 16, we're going to, this is not any earth-shattering, groundbreaking stuff. We're going to continue to work on the focal interpersonal area that we've talked about. The biggest thing that's kind of new in this phase is we're going to prepare for termination. The idea here, again, is like what brought this person in was some interpersonal difficulty, interpersonal problem. The transition from working with me as their therapist to not having me as a support, as a guide, as a caring individual is often difficult for people. We'll talk a little bit more about this at the end of our time. Actually, we'll probably talk about this more this summer. Some clients really process through termination and it's deep and meaningful. Other like, oh, see ya, sayonara. And then there's a whole lot in between. But the thing that we want to do with our clients when possible is to make sure that we're talking about the transition that is happening, gathering their feelings and thoughts about it, and processing through that termination and change with them. And then the final thing that you did for this week is you read through an article on cultural adaptations of IPT for depression. And it was actually a weird title. It's a depression, primary care, and then elderly populations. To be honest with you, I read this article every year that I've used it, and I'm like, all right, it's a nice example of, I should say it's an okay example of cultural adaptation, but it's a little confusing in the way that they lay it out. This is another example of a review paper. It's similar to the Sandler article that you read on psychodynamic treatments last week. So it gives you a nice model of a review paper. It's not a meta-analysis. It's not a synthesis. It's really just kind of a review of the existing literature and a discussion of how we might be able to improve. I think the best part of this article, in my humble opinion, is at the very end. I can't get my slide to work here. Oh, sorry. They did some focus groups with African American samples and looked at and thoughts and perceptions of how IPT might be adapted and be more effective within that particular sampling group. And they did, at the results of those 3 community focus groups, they put forward 5 specific suggestions as to how to adapt IPT. And it may be that I just know the stuff and so it's not groundbreaking to me, but part of what they talked about was adding a more kind of collectivist orientation. So instead of kind of separating from and becoming independent from relationships, building that kind of more nurturing, stable sense of relationships and being together versus being separate in our goals. They also talked about kind of maybe further emphasizing and recognizing the importance of relationships to psychological distress. So this is similar to what you're already doing in IPT, but the idea here was to kind of emphasize it more so based on the importance of relationships and relatedness within this particular sampling group. They also talked about addressing the stigma associated with psychopathology and making sure that stigma is addressed, especially in this community, to make sure that people feel more comfortable with psychopathology, seeking treatment, and how to present that to others in their environment. The one thing that I really, really like, and we've seen this a couple of times, so I'd like to emphasize it again, is the inclusion of a pre-treatment engagement session. They had some nice kind of language and modeling about how you might do this in both of the things that you read this week. And so I'm really kind of a big proponent, as you all know at this point, of really kind of making sure that you're talking to people about what treatment is, what treatment isn't. You could include the stigma part in this pre-treatment engagement session. And then finally, they talked about kind of, and again, this seems like a no-brainer to me, but it's important, but exploring kind of perceived experiences and lived experiences of discrimination, and how those discrimination, oppression, all those things have kind of impacted individuals within this culture and within this community.